All right. Well, we're live on
We're live.
Facebook.
Oh, we're live on your Facebook?
Yep.
I can't start on mine. Anyway, so what's up?
All
How's
right.
it
Welcome
going?
back to Therapy Insiders podcast. Dr. Gene Shirakabrad here with Dr. Urson Religioso. What's up, Urs, minus your mouse difficulties?
Nothing. Actually, it's a browser difficulty. I can't click on anything in the browser, and I don't want to shut it because I'm just like stuck in this tab. So as long as we're broadcasting live on yours, I'm good. How you doing, Gene?
We are broadcasting live. I'm doing well. So again, to give people a bit of a summary of this kind of new format. So we are, as we're recording now, we're live on Facebook, we're live on Instagram, just so we can answer people's questions as they come in, while also going over topics that we kind of see relevant, that we get a lot of questions on, and that we spend a lot of time really discussing. So we're 2 episodes into this format. We're
3 episodes in.
Correct. This is our 3rd episode.
Yeah.
We have 120 other episodes in the bank. So it's been fun. I think it's fun to kind of switch it up into this and have this conversation. I think it gives people really a sense of what our podcast is like, because we always talk about that we never really prepare in terms of getting the questions ready. But still, when a podcast episode goes out, there's always editing involved, right? Like when people put out episodes, they're usually edited bare minimum. It's something. So I think in this format, it really gives people an idea of what our podcast and what our conversations are like, because you get to experience it live, and you get to see that usually by the time the product is put out, like once our final episode is put out on iTunes or Google Play Store or something like that, that most of the editing is more of the quality of the aesthetics of the voice or some stuff like that, even though some people still give a shit for that. But in terms of the actual content, it's pretty much 1-to-1. So I think that's been a cool thing for people to see of where we are. My biggest thing right now is I need to pay attention to Instagram, because people are coming in with questions and joining in. So I want to make sure we don't miss any. So if you have questions on Instagram, make sure you keep submitting those, and I'll keep scrolling, make sure we don't miss any.
Yeah, it's just so small so far. All right, we do have a question from Katana7 on Instagram. How's it going? Hey guys, I'm following you for a while, and I'm interested in which techniques or seminars do you want? Well, that is I'm not necessarily sure what you mean by that. It's I think a literal or figurative or both, lost in translation here. Do I want these techniques or seminars from you? Which ones do I find interesting?
Well, go ahead. I mean, Urson, let's get out the biased ones first, the ones that you teach, and then we'll work backwards from there.
Well, I have a brand, The Eclectic Approach, and several sub-brands under that. My brand is Modern Manual Therapy. I think they're amazing courses. I think Gene would agree. He's probably a little biased himself. Haven't taken a couple of my courses and hosted my courses successfully. So if you want to learn manual therapy, the easy way, the non-minutia way, the non-systematic way, the non-commercial based model way,
It's a lot of nuns.
It's non, yeah. It's the a manual therapy course where palpation doesn't matter, where you don't need to press or guess or poke or hope. You realize you don't need to be specific. You can't be specific. Manual therapy effects are non-specific. They're mostly placebo-based and based on patient expectation, but doesn't mean that there's not still an art to that. So that's what we teach, and that is my brand. We also have modern strength training, and coming soon, modern patient education. Modern strength training is our BFR certificates, and modern patient education is how to treat typically non-responders or chronic injuries or centrally sensitized patients using patient education, pain science education, on recovery strategies, sleep, nutrition, and mindfulness.
Nice.
Coming soon. How about you, Gene?
I only feel comfortable recommending courses that I've actually been to or seen in person. So the one I'd like to think the ones that I've been to, or at least the ones that we've hosted at Recharge and through Garage Series, have been the best of the best. Anything with ICE courses, Jeff Moore, his Institute of Clinical Excellence. All those courses have been amazing. Jeff and I, again, take it from a lens of bias, but from something that we've had a lot of experience with and seen a lot. Jeff is an amazing clinician, amazing instructor. His courses are great because, just like Urson's, they make you think critically and how to implement into your practice. It's not just about getting a playbook or a checklist of techniques to do. It's about connecting with people, seeing where they are, and how to best integrate what you're learning to where they are. I think that's what makes good courses great. It's not just about having techniques. It's about knowing how to integrate those techniques into the person's life and making sure that you're always aware of the end goal, which is giving people efficacy in their own care and their own ability to take care of themselves. So Urson's courses are amazing for that. Jeff's courses are amazing for that. We had John Russin in at Recharge as well. His seminar of integrating strength training with coaching, with rehab. That was an amazing course because you get to see actionable advice of some of the best researched integration that we have, which again, Urson, is exercise and lifting. I feel like one of the biggest things that we don't get in school is loading strategy and dosing and all that stuff. John was really good at integrating that, I think, beyond some baseline rehab. So that was a great course. Anthony Lowe was awesome with integrating female athletes, pelvic health, stuff like that. That was a really, really good course that I'd recommend. So it really depends on kind of what your cup of tea is, really what you want to specialize in or what you want to learn. I can't go wrong with any of those, I'd say. And then other instructors that I know, because I've seen their material either from reviewing, giving them feedback before they actually do the course. Julie Wiebe with pelvic floor, Tracy Scher with pelvic floor stuff. I don't know. I feel like there's a lot that I'm still missing, but those are the ones that come to mind initially.
Right. I think people are always looking for a toolbox, and there's a lot of debate and negative connotation among modern clinicians about the toolbox. And people are always looking for, more techniques, or they want to get better at breathing, or they want to get better at needling or manipulation or soft tissue work. And what I can tell you after doing this for 20 years is that if you're looking for the answer, you really need to learn how to interview a patient, how to connect with a patient, and how to motivate your patient, and how to empower them. Because every time someone reaches out with a very common question to me, maybe it's an online mentee or just someone who reads my blog or is in my premium group, it's usually, hey, I'm seeing a Achilles tendinopathy and I've done this, and this. And it's just this laundry list of common treatments. And to me, my question is always the same, because basically any technique that you're going to do that's passive like that, any kind of passive manual therapy, tissue technique, and needling technique, they're all kind of passive because they don't really get the patient moving. They might give them a window of opportunity where they can now load and move in a threat-free manner, but it's really up to them to maintain that. So my question is always, what have you taught them? What is the home program? Are they compliant with it? And what is the dosage of that? It's if someone can leave your clinic better and they don't come back better, either you didn't properly educate them or they're not compliant with the home program. So that's the thing with that. It's not like technique courses are not useful. It's just that levels of courses, and this is something Greg Lehman talks about. He's kind of against, the 5 levels of manual therapy, and I'm not sure how I feel about that now. I don't know if there's 5 levels or 6 or 7 levels needed. You might need 2 or 3 to kind of basically refine your techniques and learn more techniques after the basics. But often the basics are all you really need if you can connect well and educate your patients well. So that's my feeling on almost any manual therapy course, because people always ask, what do I think of X brand? And sometimes I have good things to say, and sometimes I don't have good things to say. And if I don't have good things to say, I'm just not going to say it publicly.
Yeah, I agree. That's a good philosophy. But it should be all about ROI, not necessarily ROI of CEUs or ROI of this is how much money I spent on a course and was it worth it? This is the time I invested. Is the investment of my time 10x, 20x to the amount of patients or people I'm going to help? And not just this is a big thing here. It's not just about the first week when you get back, because you're super jazzed up. You learn these new things. You're like, oh yeah, I'm going to help so many patients. Oh yeah, I have this case that this will be perfect for, and you do it for a week and then you never do it again. All right. So ROI is not a short-term metric. ROI is a long-term investment. So are you integrating? Are you doing this after the first week, after 3 weeks, after 6 weeks? So that's how I gauge courses. Am I taking even 10%? If I have a 10% integration of what I learned in that course over a span of 6 months plus, then that's a good course to me.
Right. Essentially, what you should be looking for in a course is the same thing that you should be trying to do for patients, because Gene and I have said it before, what you're really trying to do with the patient is change their behavior. So does that course overall change your behavior? Because again, like Gene said, yeah, you come back with all these new techniques and assessments, and maybe you even told your patient on Friday that, hey, I'm going to this amazing course and I'll have new tips and tricks to help you on Monday. And some people will be ecstatic about that, and other people will think like, hey, what, am I just a guinea pig? And why didn't you know this stuff before? So that could go either way. But overall, a course has got to change your behavior. You got to be able to adapt and integrate it to it. And in terms of ROI, that's why I don't really like the whole levels of courses, because you think you're getting better at a particular technique. But honestly, since manual therapy is really non-specific and you can't get better at it, you might be more comfortable at it, you might be able to deliver it better based on a certain presentation you have or a certain explanation that you've been practicing, or you hear a new explanation from a different instructor who's maybe a more charismatic speaker. But overall, the amount of money and time you put into levels of techniques often doesn't translate to significantly increased outcomes. There's just a diminishing effect of increased outcomes with every level of course. That being said, it's easy for me and others who are kind of experts or have gone through a whole series of courses on for their certificate or a fellowship or a residency to say that we can cut corners. And my buddy Charlie Wangeroff has often said is you can't cut corners in a system unless you know the whole system. And I think to some degree that is also true. And certain systems are definitely going to make you more effective than others. It's just that those systems should definitely integrate patient education. That's why I'm such a fan of MDT or the McKenzie method, because it's all about patient empowerment.
Yeah, I mean that all makes sense. There's so much variability, and yet still so much of the same information being shared. So it really is about the competency of the presenter. Like you said, are you connecting with the presenter in a way that they help you understand of how to integrate? And there's just, if you can go to the course and feel like it was justified to go there, especially at the point now where there's so much information out there for free, and webinars and videos and podcasts like this that you're getting information. If you feel like you went there and it was time well spent, that's a good start. But again, it should be a long-term ROI piece for the course. So there are some suggestions. Hope those help. We say we get into some of the questions that we got last week, Urs.
Sure. Do you want to read the one on cervicogenic dizziness? Or basically it was, what do you guys think about cervicogenic dizziness?
Yeah.
What do you do for that?
I think that was pretty much it. Cervicogenic dizziness.
Well, I mean, I guess I'll be the first to start, and this is not obviously a time where we can talk about exactly what we do, but I would get, at one point, my caseload was probably about 80% TMD. So I saw a ton of upper cervical issues. Obviously, what I would like to say is every TMJ patient or a TMD patient was a cervical patient, but not every cervical patient is a TMD patient. Mm-hmm. And I think dizziness and vertigo, obviously there could be a cervical component and there can also be a vestibular component. And I am by no means a vestibular expert, but I would often get referrals for vestibular rehab, and all I would do is a simple upper cervical and cervical screen, and with just some repeated motion testing and provocation testing, depending on, does repeated protraction increase their complaints, or after looking at the history and what makes them better, what makes them worse, and does repeated retraction or side bending or retraction and side bending, retraction rotation, do any of those things along with some manual therapy to the upper cervical spine, does it alleviate their complaints? And is it a simple thing that I could teach them for home treatment? If if it does improve their dizziness and it does improve their headaches and any of their cervical issues that kind of go along with that, then I would consider it not vestibular. If all of those repeated motions were negative and kind of targeted treatments to the upper cervical spine, particularly, do not affect it, then I would just refer them on because I know my limitations. So that's basically how I look at cervicogenic dizziness. Can you affect it with targeted treatments or movements, repeated motion, or loading strategies to the cervical spine?
Yeah, I just take my patients on a roller coaster. So when I see the patient on the schedule, hey, cervicogenic dizziness or dizziness, we go on the whirly whirl, the loop-de-loop, and that usually knocks it out pretty quick. If I don't have that available, if there's no availability of a roller coaster, very similar to yours, kind of try to get like with anything that's subjective, you should get what we say up to 80% of an idea of how to treat the person and what's going on before you even put your hands on them. Then, I think that one of the biggest things with cervicogenic dizziness, aside from really determining, like you said, Urs, if it's cervicogenic dizziness, is that first initial evaluation to see how centrally sensitized the person is. How absolutely guarded are they? Because dizziness is a huge vulnerability for a lot of people. It literally shakes their world. It puts them in a place where they don't know how to deal with what's going on. And they become a lot more guarded than with more traditional pain, because people don't want to throw up. People don't want to feel like they're out of control. So that's one of the first things I see is how long has it been going on, and how really vulnerable are they, and how willing are they to let me play around with their neck, move them around. So I kind of ease into that conversation of how long has it been going on, how in control do you feel? And, that becomes a nuanced conversation between you and the patient. Sometimes you have to start that examination in sitting versus in lying down, especially if they say, as soon as I put my head on the pillow, I feel really out of control, or I feel really dizzy. So, chances are the first thing you're not going to do is just throw them down and say, all right, here we go, strap in, Hoss. Let's get it going. Yeah, exactly. Get the bucket ready. We're going. But if you feel like it's a vestibular issue, and I'm the same as Urs, and I'm by no means a vestibular expert, if I feel like it's more of a vestibular issue, chances are I'll send them to somebody that I know does vestibular rehab versus me trying to do a half-ass Dix Hall Pike or something like that. But if they say, I have a lot of neck pain, it starts with neck pain and then the dizziness comes after neck pain. If you start to break down neck pain versus headaches versus dizziness, or neck pain with dizziness or headaches with dizziness, all those things, if you look through your cranial nerves, if you elicit dizziness and then do a cranial nerve exam and it's all negative, then you can start getting into more C-spine repeated motions. Obviously, upper cervical manipulations can be really effective, usually most likely not on the first visit, depending on how guarded they are, but upper cervical manips have shown good efficacy with cervicogenic dizziness and stuff like that. So that those are usually on my list of go-tos, but it's more of a delicate, I'd say, process than more traditional, let's say, mechanical neck pain or something like that. Did you mute your mic on Facebook?
Sorry, yes, I did. Yeah, what Gene said is true. I think looking for those concordant symptoms of neck pain and headaches, they're probably it would be rare if they didn't have some sort of, especially because it's a overall sensitization of the cervical spine, particularly upper cervical spine. And if the repeated loading strategy was negative, it's not like I just all of a sudden refer them to a vestibular specialist. There are other things I would rule out. Looking at typically their breathing pattern and hooking them up to this machine I have called a Capno trainer, which for those of you guys who have taken my eclectic approach to TMD, I demonstrate that it measures CO2 output. So if you overbreathe and you essentially exhale too much CO2, that could throw off your acid-base balance or your pH balance in your interstitial fluid and your bloodstream and your lymph fluid, so basically every major fluid in the body, and that's just been overbreathing has been associated with unexplained complaints when all other things are negative. So there are other things I look at. It's not like I just automatically assume that it's vestibular if repeated motions are negative, but I just didn't want to get into too much specifics. So there are other things that potentially you could look at other than cervical spine, I should say.
Yeah, for
Even
sure.
if you're not a vestibular expert.
Absolutely. Absolutely. All right. Hope that answers it. What else we got, Urs?
Well, one of my buddies, Dr. Aaron LeBauer of Cash PT Nation, was telling me about a question that he often gets from a particular user on Twitter, and maybe it might be one or two. And I think this, Gene and I are somewhat qualified to answer this. I don't know if we have any metrics or data, but the question is essentially, so for Cash PT, where's the data when it comes to being able to provide a better experience or just being better than traditional insurance-based PT? That was my understanding of the question. What do you think about that, Gene?
That's definitely a loaded question. It's a bit of it bugs me a bit, Urson, this concept. And I work in, recharges based on an out of network model. So we don't take insurance. But I still feel like basing our success or basing a UVP on time is a recipe for disaster. That is not a scalable thing for a business. You can't say, well, we're going to spend an hour with you, therefore that's a positive. We essentially take out time out of the equation here. So we have sessions. People are coming to see us for a session. People have no idea what an initial evaluation is. People have no idea what a reevaluation is. People have no idea what a treatment is. People know they're coming to see you, especially if it's the first time. They're coming with a lot of unknowns. They're coming with a lot of preconceived notions based on their previous experiences and based on what you put out. If they do some research on you on social media, on your website, all these things. So that creates an experience for them before they come in. So when they do come in, or if they call and they're asking the questions, but they're asking questions and what they're asking isn't necessarily what they actually want to know, because people have a hard time asking a question that they don't really know how to frame or phrase. So they're asking you questions like, well, am I going to be one-on-one with the physical therapist because maybe that they had a poor experience previously with a tech aid, or maybe their friend went to a physical therapy place and they only saw a PT for 10 minutes and they had a bad experience and they based it on that. Are you going to see me, or, is this 40 minutes, 40 an hour? But hardly ever, Urson, does somebody call us and say, are we going to spend an hour together, or are we going to spend 30 minutes together? Or are you going to deliver really quality care for me? Like, they don't ask that question because they assume it. They ask questions like, do you take my insurance? Or how much is this going to cost? Or can you help me? Right. But ultimately, even the cost questions, what they're trying to ask is, am I going to get value for the time commitment? Am I going to get value? Are you going to help me? Is this going to be worth my time? And we have to do a better job of answering that question without saying, well, because we take cash or because we don't take insurance, you're going to spend more time with us, and more time equals better care. Because that's not realistic. It should be, you're going to spend quality time with us. You're paying money to spend quality time with us, to have more control, and ultimately to have an experience. We're delivering an experience, Urson, and delivering an experience doesn't mean you'll spend more time with the person.
Right. I have a counterpoint to that, but at first I will absolutely agree. I mean, there are people who pay me for, oh, he left the Instagram. What happened?
I got kicked out.
Too long?
Maybe.
Anyway. So anyway.
You might invite me back in?
Yeah. Okay. There are people who pay me for an hour, and sometimes I'm done with them in 30 minutes. I had one guy who paid me for 3 hours, and I was done with him after an hour, and he drove for like 5 hours. He's like, well, why don't you just mentor me for 2 hours? So you're right that no one really wants, when you go to a restaurant, you assume certain things about a restaurant. You assume that you're going to have a nice experience, good service. You want to know what can they do for you. My counterpoint is, though, I would say that the reason why the majority of us go into Cash PT is so we can provide a better experience. And I would say the ability to provide a better experience without being tethered to a ton of paperwork, you don't typically go into Cash PT, charge hourly rates that are more expensive than the most expensive trainer and massage therapist in the area, because that's usually what I recommend. You do it so you can spend more time. I don't really know too many Cash PT practitioners that are booking 4 people an hour, like your kind of typical, what I feel like is your typical Buffalo clinic where everyone sees 4 people an hour. Not to call out Buffalo here, maybe that's what the overbooking is, but every time I say that, people in other areas, people are like, oh my gosh, that's so much. So I think we will have that ability, but absolutely, time doesn't mean you're creating that valuable experience, or that you're educating the patient, or even connecting them. You can have it's like watching a bad movie for a couple hours. Just because you pay for a movie that's 2 hours long doesn't mean you're going to enjoy that movie or get anything out of the movie. But I would say that, so where's the data? That was the original question. There's probably no data for that. I mean, I'm not aware of any studies that look at the outcomes, because can a busy overbooked practice still have good outcomes? Sure, if they have a bunch of personal clinicians and overall they're mainly focusing on a home program. Absolutely. I mean, as long as they're doing the right thing, it might take them more visits, maybe a little more utilization. Is the outcome is essentially the same? Probably. But like I said, I don't know too many people who get into Cash PT to overbook themselves.
Yeah, again, it comes down to, I believe it's just faulty. It's faulty logic, Urson. It's biased logic, and it's coming from, I think, from best of intentions. But again, it's a lot of the marketing for Cash PT or private or out of network physical therapy. It's based on the clinician's bias, or of how the clinicians wants. Like even the stuff that you said, you're not going to see 4 patients an hour. You have less paperwork. Like that's a benefit to the clinician. The patient doesn't give a shit about that, right? The patient wants to be taken care of and wants to have better outcomes. And you can do that seeing 2 patients an hour. Maybe you can do that seeing 3 patients an hour, depending how systemized you are and how effective you are. But that's not something that necessarily needs to be marketed or really pushed to the people. Again, it's the time piece of it. When you market to the timing of it, you're anchoring yourself to a metric that is inflexible. Time is not scalable. You cannot scale time in business. And that's a big problem when you're marketing it. And when you're connecting time to outcomes or time to quality. Like you said, if all of a sudden you get to 45 minutes and at 45 minutes, you're like, well, we're done. The patient's like, well, you said this is an hour treatment. So you've biased them. You've noceboed them based on time. And even though you know that it's going to be a law of diminishing returns after this point. So then what? I think what Cash PT offers, what out of network offers, is so much more flexibility and the capacity and the really the ability to create an experience. I mean, that's what we have. We have the ability to create an experience for people. Not to say that you can't if you practice in network, but it's just, I feel like we have a little bit more flexibility to do that and to shape it and do what we want with it. Is your Instagram still working?
You got kicked out, and yeah, I'm still live, but I tried to re-invite you, and I couldn't do it again. So
let me restart it. It's just too much truth for Instagram.
Too much. Instagram cannot handle. Instagram believes time is a good metric for quality. Time equals quality on Instagram, I guess. No, Jen, I don't love overbooking myself. Some people might. Some people might be like, hey, I love treating 6 patients an hour. I'm not one of those people.
All right, hit me in, Urs. Let's see how long before we can explode Instagram again.
Okay, so we only planned on going half an hour anyway, right?
Yeah, how long have we been talking?
It's been about half an hour.
All right. Well, let's finish out with one more question then.
One more question. All right, let's see. Someone wanted to ask a question. Jen Crane, Circ Physio, asked, you don't love overbooking. That was a question. I am out of questions. Any more questions?
Jared just asked a question on the Facebook, Urson, on the Facebook.
Yeah,
Would you say that it is impossible to measure an experience or conduct research around it because each patient's experience is subjective? That's a good question, Jared. And no, it is not impossible.
It is not impossible.
It is actually very possible, and it should be done. You have Net Promoter Scores, NPS. You should have internal surveys. You should be sending out surveys to your patients, asking about the experience. We do that with all our members at Recharge. We have a little survey that we developed, a questionnaire that we send out to them every cycle, so every 3 months for us, and it helps a lot because you'd be surprised what people are focusing on that you're not, because you're focused on running the business, you're focused on delivering this macro experience. They're focused on the micro. So a lot of the details, a lot of the nuances of the experience get lost because you're not focused. You can't focus on every single thing, and you can't think through every single person's lens. That's just not possible. We try to, in the moment when we're treating people, when we're talking to people, that's emotional interviewing, that's having an emotional IQ, a high one at least. But you never know, especially when you make them anonymous, when people have the ability to share without putting their name to it, then you should really start to learn about how that experience is going. But that should be done all the time, and it should be a consistent part of business.
Right. It's I like to ask people for reviews, but I think the Net Promoter Score and surveys are a good way to do it. And you'd be surprised. I think the metric is basically for every one verbal complaint you have, there's 20 nonverbal complaints, and you'll be surprised because some of their people, and I told us on the Untold Physio Stories podcast once, where I went to go mentor someone at his clinic, so it was different because I didn't want to kind of take over so many treatments. I wanted to more just mentor him, but he said, "Hey, you know what? I'm having trouble with this patient. Why don't you just jump in and see what you can do without me, and I will just watch." And I think that's tough because patients weren't expecting just some guy from out of town just to kind of take over the treatment. And I remember there was one woman who I thought I really connected with the most. And I thought I sat with her for 45 minutes and described to her why this might not be working, why she might just need to kind of take a break, or maybe potentially focus on her nutrition and her sleep and other recovery strategies. And I thought, Tina, that we both thought that went really well. She kind of smiled and shook my hand when we were done. And she was the one who complained the most afterward. When asked about, he's basically like, "Oh, he just said that my diet was bad. And, I need more therapy after like 30 sessions." So you'll be surprised because I think most people are cognizant of they try to be cognizant about your feelings, whether or not it's constructive or not. And it's usually not constructive. If they have something constructive to say or something that you should hear, they don't want to tell you. Sounds like my puppy is barking. If that's coming over the microphone, I have no. Okay, good. I'm glad it's not.
Nope.
So yeah, it is measurable in the end, though. I think it's experience is something that's measurable.
I think a fundamental question that should be asked before that question is what is a great experience? Even more so, what is a great experience unique to you and to your company? I think that for some reason that question doesn't get asked. And when it does get asked, the answer isn't planned out and detailed enough, because an experience has to be a fluid, it has to be a fluid plan. It has to be determined. It has to be iterated and reiterated. And it has to be a living, breathing thing based on your personality, and more importantly, based on the consistency, right? One of the biggest things, because you have to take a step back. This is about people. So ultimately, this is about psychology. This is about understanding human nature and thinking about what people like. But you also have to think about what people don't like. People don't like change. People don't like uncertainty. People don't like the unknown. People don't like fear. All these things that can deter people from your experience, right? People like pleasant aesthetics, but that comes under consistency. So you have to look at these broad concepts of human nature, of who people are, that is pretty much consistent with every single human being. And that goes into the experience, right? You take these pieces and you take them away from people. So sometimes you have to do negatives before you do positives. Negatives being taking away things that could potentially hinder an experience. Then when you take those away, then you can start to build on, which creates the uniqueness. So you have to do the baseline things well first. That's I feel like that gets lost in the experience piece of developing experience, is people blow past these fundamentals of human nature that have to be integrated no matter what. You have to have that. You have to be a safe, consistent place for people, because life is not that for them outside of whatever business you're delivering to them. Life is hectic for people. People are stressed. They have enough uncertainty, enough shit coming at them, that your business, your company should be a reprieve from that. It should be a safe haven, a consistent, amazing thing. And that should be a baseline competency. And then on top of that baseline competency, you build into the unique little touches, the little micros, the little details that you will deliver to them that somebody else won't. Micers.
Oh, agreed.
Mic check.
Well
Mic
said.
check.
Yes, mic check. I know. You know why? Because I could just hear you echoing. If I leave it on, it echoes. So I'm just trying to turn it off just for quality.
There you go.
I don't know how the audio is going to come out on this one. So
we'll adjust. Give people more incentive to tune in live.
That's right. For the best possible experience.
By the way, for people that are watching now, do you like this live format? Do you prefer having this as well as eventually a podcast on iTunes to listen to? That'd be good. Speaking of feedback, Jared, here we go. We're measuring the experience right now. That's right.
We'll send out a survey. Oh, we just got a heart.
There we go. See, we got a heart. Everyone's happy. Our dopamine's going.
That's right. Thanks,
Awesome.
Corey. Corey says definitely. Yes, love the videos. Thanks, Jen Crane. Follow at CircPhysio. Circ_physio on Instagram.
Awesome. What's up? We got Jordan checking in on Facebook.
I know. Sorry if you guys normally follow me on Facebook. I had some browser issues, so next time we'll broadcast live.
We're distracting Nathan from writing notes.
I know. Yes. What would you rather be doing? Listening to us, Therapy Insiders live, or doing soap notes? Hey, you know what? Do your soap notes after work.
Yeah, please. Look, first of all, by the way, we cut down our potential talk about Avengers. I don't think we didn't even have that our normal like 20 minutes of useless talk. We went
it's not
right
useless.
into the content. Well, for people, I mean, it makes us happy.
Yeah.
But we went right into the content this time around, Nathan. So all your notes, it was an investment in time of learning. So there you go.
For sure.
I hope that helps.
We'll talk about Avengers some other time.
True.
Gene hasn't even seen it, but he just went on Reddit and couldn't stop himself from spoiling the entire movie.
But look, I see. Look,
but the experience of actually watching it,
we saved it towards the end.
The experience of watching it, it's still,
for those of you that are still sticking around.
It's not really that surprising, but yeah, it's an experience.
We're here for you, Nathan. We're here for you, buddy. Look, first of all, if you don't want to, if you tuned in for business and physio content, you can tune out now, because it's all good for the next
let's talk about Avengers.
It's going to be nothing in that realm.
No spoilers, Gene.
No spoilers. Look, I read the comics before. It was one of the biggest comics. First of all, I was never a huge Marvel fan. I was always a DC fan. Superman's my favorite superhero growing up. So when this whole Infinity Gauntlet series came out, it was awesome. It was really cool to see, because if you haven't read the comics, Thanos is one of the better villains in Marvel. I feel like one of the best ways to determining a good comic book or any story is the agonist-protagonist relationship, or antagonist-protagonist. So if you don't have a good villain to the hero, it's just not a good story. If you don't have a good challenge that the hero has to overcome, there's no transformation, there's no journey in it. So that comic was awesome because a lot of shit went down. So I was curious, and then the spoiler popped up in front of me, and I wanted to know, because I know the story anyway, Ersin, and then I read it, and I was more excited to see the movie after reading the spoilers, because I wanted to see how the filmmakers made it happen.
Right. Seeing how they made it happen is really good. I mean, I think Thanos is a great antagonist. The MCU has a problem. I think only like the Netflix shows or Shield, because they actually have a serial format over, like 12 shows or 24 shows or whatever it is, to actually develop a character. It's hard to for characterization over 2.5 hours, but since we've already had 10 years of characterization of all the protagonists, they could actually devote almost all the screen time. Thanos probably gets more screen time than anyone, and that's what makes him it's also well written, and it makes him a very compelling villain. So
nice. So for our next podcast, one of the big things that I want to talk about is stories. And if you're part of our Facebook group or the UpDoc Accelerator group, I've talked about stories a lot, but this has been one of the biggest things that we've been integrating into marketing, into consulting, into developing content is making sure people understand story narratives, because content should never be arbitrary and it should never be spontaneous, or it could be spontaneous, but it shouldn't be without structure, and it should follow story structure, a good story structure. So in the next episode, I want to talk about what really a good story structure is and how to create content based on narrative, essentially.
Right. We should link to that Mr. Rogers podcast, or the Mr. Rogers interview podcast. That's basically all about story and great interviewing.
Yeah, that was a really good interview.
That was spontaneous, but it still turned out amazing.
Well, because he knew that the interviewer knew how to guide the interview so it unfolds in a narrative. And that's the biggest thing. That's how our brains work. That's how people tune in, because there's so much information and so much stuff coming at people that the only way they tune in is with that. What do we got? Someone on the director interviewed in DC Wednesday evening. They spoke of how they wanted show Thanos as the hero and villain, and him being exactly. So that's how villains should be. Like you should understand why they're doing what they're doing. Have a deep understanding of their motivation. Might not necessarily agree with the execution of it, but at least understand why they're doing it.
It's also why Killmonger is such an amazing villain.
Right, for Black Panther.
Yeah.
Because
you really feel for his struggle.
The struggle is real, Urs. The struggle is real. All right, so that's it. That's Therapy Insiders Live, our third episode in the books. Thank you for tuning in on Instagram, for tuning in on Facebook Live, and if you're listening to this on iTunes or Google Play or wherever you listen to podcasts, appreciate you tuning in this week. Catch us again next week. If you haven't subscribed on YouTube and iTunes, please do that at UpDoc Media, Therapy Insiders. You could also check out our UpDoc Media Facebook page and Urson's Modern Manual Therapy Facebook page to make sure you get to submit your questions live next week.
Right. It's modmt.com/Facebook, Instagram, YouTube, or Twitter. So that's how you get to any of my social media.
Awesome. If you come up with questions after listening to this, you can leave a comment on the Facebook thread on the UpDoc Media page. Urson and I circle back and answer questions that we didn't see, or leave a comment on this Instagram, on the Instagram Live page as well. I think that stays up for 24 hours or something like that.
All right.
And we'll check in. All right. So thanks for tuning in. We'll catch you again next week.
See ya.